Joel Topf with Nephrology Times. I'm here with Michael Lazarus Award winner, Jeff Perl. Welcome, Jeff.
Thanks.
Okay, well, first of all, thanks for making the trip from Canada. That's not as easy as it used to be.
No. Luckily, they let me in.
It's going back that might be the problem.
Right,
I
exactly.
hope there's no problems at all.
Right.
But no, thank you for coming in. You just gave your talk accepting the Michael Lazarus Award. It was a barn burner of a talk. Really, I've seen a bunch of these award winner talks. This was among the best.
Thank
you.
you.
Had a lot of heart. I'm just gonna kind of pick at the talk because I want to talk about some aspects of it.
Okay.
One of the things that I loved is that you started off with the talk, which was like, who's Michael Lazarus? You had an opportunity to meet him. Why don't you fill us in?
Yeah, I mean, it was really interesting to talk to him. He's obviously been retired for quite some time. And it was just nice to hear the evolution of his career for somebody at my stage, to hear how he started off as a fellow, wanted to learn more about dialysis, and there were only a handful. It was not like he had many programs to choose between. He had like 4 or 5, and then decided to go to where he went to at the Peter Brigham Hospital, and then, from there decided that he wanted to go to a large dialysis organization and have a bigger impact on a lot more patients, which he clearly
He
has.
went to the biggest organization and
Yeah.
had the biggest impact as a
And it was
medical
just
director.
nice to hear how much he enjoyed training and working with fellows and making sure that fellows got involved. And he still said that people in academics really need to have a solid clinical focus too, which I thought was really
Amen.
inspiring
Yes.
to me. And I resonated really well with me.
Well, that's interesting because at the beginning of your career was really about membrane biology.
Yeah.
And that you had a moment where you had to make a decision. There was a clear kind of two paths diverged in the woods.
Yeah.
Why don't you talk a little bit about that?
Yeah. I think at that point, you're very junior, and it's very easy to do what other people think you should do. But I think if I had to give advice to people, it's go with your heart and what you're really going to have passion about. I think a lot of people get into research and might be doing a specific project or an area because they have so much regard for their mentor. But sometimes it's really important to say, is this what I really want to do? Because you're going to be living, breathing, eating it day in and day out if you're going to be doing research in it. And it really has to be something that lights a fire under you. And as much as I found that stuff interesting, I couldn't relate to it in terms of the day-to-day management of our patients, which is what, kind of inspired me to get into research in the first place.
And I think it's pretty clear, important to understand that you didn't leave research.
No.
You just left that basic science, membrane biology.
Yeah, more translational. Yeah. It had to be immediately relatable to the way we care for patients. And so to me, the research that excites me the most is like, okay, so we do a study. Now tomorrow, here's what we're going to do differently based on the results. Whereas I think some of the more translational basic science stuff, yes, it's foundational, but to get to the bedside is years and years and years of many more research milestones to get there. So I'm sort of like I'm a fast food researcher. I want it, and I want it to translate it to the bedside.
That's awesome. And I think a lot of the work that you've done with international guidelines is about that, right?
Yeah, exactly. And so I think I think with the guidelines though, we actually know what to do, and I think there's a bigger problem that we're not doing it, and maybe we're not all doing it. And so I think that the guidelines are one opportunity for sort of knowledge translation, but they're one of many. And I think that we really need to think about other translation pathways so that we can get the information to the people that need to hear it.
So one of the information sources you kept coming back to was the PDOPs, the idea that we could see variability in how we deliver this, and like, what can we learn from that variability?
I think we can learn from that variability that, again, even though there's things that are evidence-based, like antibiotics at the time of catheter insertion and exit site prophylaxis, there's still places that aren't doing that. And I was actually surprised to hear, for example, in Japan, there's no exit site prophylaxis at their patients because they're really concerned about antimicrobial resistance, and they're really worried about prophylactic antibiotics in general. So I think that, to me, that opened up a whole area of sort of antibiotic stewardship, and maybe we are needing to evolve in terms of what we're doing and the antibiotics we use, but also understanding that some places still aren't following the guidelines.
Excellent. You talked also about the potassium being
Yeah.
related to that. Why don't you share that anecdote?
Yeah. So I think with the potassium is important as a.
I'm sorry. I just wanted to clear that the low potassium is a risk factor for peritonitis.
Yeah.
Okay.
So low potassium is a risk factor for peritonitis, and I've been guilty about research like this, which is observational. You show an association between A and B. Does A cause B? Is A associated with B? If we change A, will that impact B? And a lot of people just sort of leave it at there, right? And a classic example in nephrology is statin use. So for cholesterol use and outcomes in dialysis, I'm sure there's been observational studies that have shown a benefit of cholesterol and outcomes. But until you do the 4D, until you do the SHARP study, until you do those randomized controlled trials, you really don't know if the observational data is going to shake out. And what I really like about potassium is here we have a story where low potassium increases the risk of peritonitis. And then it's always like, well, is it the low potassium, or is it the type of patient that has a low potassium? Is it a nutritional issue that makes that patient more susceptible to peritonitis? And then we're left in this ambiguity saying, yeah, well, maybe we should replace potassium. But what I really liked about this particular area is our group in Thailand said, that's not good enough for us. We're going to take it to an interventional study. We're going to randomize patients to be more aggressive about potassium supplementation or less aggressive, and show, which they did, published in AJKD, that that aggressive supplementation and more a more proactive potassium supplementation reduces the risk of peritonitis. So we have a really nice evolution of research where observational study, randomized trial, outcome, and now we can really wholeheartedly take some advice back to the bedside.
That's outstanding. One of the things that touched my heart is you have twins.
Yes.
I have twins.
Boy and a girl?
Boy and a girl twins.
Right.
Okay. What did you learn? What did you learn being a father of twins? Because I'm sure we have a lot of father twins. I want to hear your lessons.
Well, I can just say people say it must have been so hard to have twins, and so you're basically dealing with two kids born at the same time, so it's double the diaper changes, double the feeds, double the amount of work. So you're on overdrive in the beginning. But actually, if you think about at 6 years, if I were to have had two kids that are 3 and 6 years, they wouldn't play with each other, they wouldn't keep each other company. So now we're driving to the same school, they're doing kind of the same activities, they've got the same circle of friends. So now it has kind of been advantageous that they're the same age because they keep each other occupied. So early upfront work, later benefits. And I kind of say
the total number of diaper changes does not reduce if you separate the kids. They're still going to poop the same amount.
No. And someone once asked me to give a talk about fear around home dialysis.
Okay.
And it was called home hemophobia or something like that. And my analogy was, I've obviously, never been on dialysis, but I thought, the scariest thing in my life so far was having kids and never having kids before. So to me, like hemophobia was like having one kid, and I said home hemophobia was like having twins. It's just doing it yourself, doing it at home, double the work. I said, that's the only thing I can think of. It's just like next level fear.
Outstanding. Hey, congratulations
Thank you
on this. This is amazing.
Thank you.
Thanks for coming to the NKF Spring Clinical Meeting.
Thank you.